pathological conditions, but also for assessing a patient's response to treatment. Therefore, you should auscultate before and after any respiratory treatment, such as administering a nebulizer. Hi, Jada.
Hi.
It's almost time for your asthma medication, so I was just gonna have a little listen to your lungs. Is it okay time for you?
Okay.
Okay, great. Let's just take off your scarf. So ideally for auscultating, you should have, your patient should be calm, not crying, and able to breathe deeply. You're going to want to auscultate anteriorly, laterally, and posteriorly using a systematic and orderly approach so that you can compare sounds on either side. Do you mind if we just undo your sweatshirt there?
Of course.
Warm the stethoscope before placing it on the child, and try to avoid placing it over clothing or hair. Press firmly and try not to move your hand or have the child move. Try not to have the child move while you're listening. Great. So just take a deep breath. And the other side. Great. Deep breath in. Breath sounds can be classified as normal, abnormal, or adventitious. Adventitious sounds are sounds that shouldn't normally be there. When assessing breath sounds, try to imagine the structure of the lungs and whereabouts you're hearing the sounds. Normal breath sounds sound like sort of soft swishing noises. And here's an example that was recorded from an auscultation of a 2-day-old baby girl. One of the things you're going to chart on is air entry. Diminished or absent breath sounds are always abnormal and must be charted. The absence or the diminished sounds might indicate the presence of fluid, air, or solid masses in the pleural space. So, what you want to do when you're auscultating is compare the upper and lower lung fields as well as the right and left sides, and note where you hear any diminished air. Wheezes are high-pitched musical sounds heard continuously during inspiration or expiration and are often heard louder or only on expiration. They don't clear when coughing. They're caused by a bronchoconstriction or bronchoobstruction, often from some kind of secretion, and can be heard over all the lung fields. Note whether you hear wheezing upon inspiration, expiration, or both, and whether it's mild, moderate, or severe. Here's an example of a wheeze. Crackles are also known as rales or rawls. There are two types of crackles. Fine crackles are short, interrupted crackling noises heard during the end of inspiration or the beginning of expiration, or both. It sounds like crushing cellophane and may or may not change with coughing. Coarse crackles are medium or loud crackling or bubbling noises heard during inspiration, and they're not cleared with coughing. They may sound more moist than fine crackles. Crackles are most commonly heard in the right and left lung bases and are caused by secretions in the terminal bronchi or alveoli. The crackles are caused by the sudden reinflation of groups of alveoli. Note where you hear the crackling and whether it's mild, moderate, or severe. Here is an example of crackles heard on a 9-year-old boy with pneumonia. Stridor is a high-pitched noise that indicates a narrowing of the upper airway. It's usually caused by edema, inflammation, or obstruction and can be heard on inspiration or expiration. In children, stridor is often caused by a foreign object, croup, or inflammation of the trachea. Here is an example of stridor. Sometimes we talk about increased work of breathing, and what we really mean is that a child is working so hard to breathe that they're sort of recruiting additional muscles in order to meet their oxygenation needs. Sometimes the location of these additional muscles is helpful in sort of giving us an idea of where the problem might lie. For instance, if you have substernal or subcostal indrawing or retractions, it may be indicative that the problem might be related to the lower respiratory tract. Whereas if you have some supraclavicular indrawing happening, that might be more likely to be related to problems in the upper respiratory tract. Other spots to look for indrawing or retractions are in the intercostal areas, which in and of itself isn't necessarily a sign. You might see some indrawing there just happening with everyday breathing, but you want to look for some additional signs there. Also, sternal indrawing and the tracheal tug, which happens right here. That's a pretty serious sign. Also, nasal flaring can also be common. This just happens right at the nares. Again, with any indrawing or retractions, you're going to want to note in your charting whether they're mild, moderate, or severe. Cough. Coughing sounds may be the most difficult to classify. There seems to be a lot of different descriptors used, and it's sort of hard to arrive at a standard definition. But for the purpose of this training, I have broken down the descriptors into 3 categories. 1, timing. Here we use frequent or occasional to classify how often the patient is coughing. If the patient is having a severe sudden coughing attack, we would describe that as paroxysmal. 2. The second category is concerned with whether the cough is loose or choky. If the patient has a wet or productive cough with secretions, we refer to it as loose. Here is an example of a loose cough. If a cough is non-producing or dry, we refer to it as choky. Here's an example of a choky cough. Number 3. The third category is the severity of the cough. Is it mild, moderate, or severe? Sometimes we describe a cough as croupy. Croup is an inflammation of the upper airways that causes a distinctive barky cough or hoarseness, especially when children cry. Croup is usually caused by a virus like RSV. This is what a croupy cough sounds like. Well, that's all the time we have together. I hope you found this video useful and that you'll breathe a little easier the next